want you to look right here at my forehead. Follow it with your eyes. And up and down, up and down. Now look right here but at my nose. Good. Look up. Excellent. Okay. And the left ear. Good. Examine the ears. I want you to wrinkle your forehead up. Go like this. Stick your tongue out at me. Good. Can you hear me? Mm-hmm. How about over here? Hear that? Any difference between the two sides? No. All right. Open your mouth wide. Lift your tongue to the roof of your mouth. Good. Relax your tongue. Say ah. Ah. Excellent. Thank you. Good. Look right in that direction. Look up just a little. Good. Okay, excellent. Thank you. Now I'm going to palpate the skull and the posterior aspect of the neck, occipital lymph nodes. And I'm going to move to the back and palpate the anterior neck. Submental nodes, submandibular nodes, and submandibular gland. Anterior triangle down the front border of the sternocleidomastoid, right down to the insertion of the sternocleidomastoid. Posterior triangle, posterior border of the sternocleidomastoid, preauricular, postauricular, supraclavicular fossa, and the pretrapezius nodes. Thyroid cartilage, cricoid cartilage, trachea in the midline. I can feel his thyroid easily right now, but we'll have him swallow. Good, and roll the thyroid up under my hands. And you're palpating right underneath the occiput, and then forward, and then down the back of the neck, rolling the tissue underneath your fingers. Okay? And then down the front of the sternocleidomastoid, retract the muscle a little bit so you ensure you're feeling under the anterior border. And then right down to the insertion of the sternocleidomastoid, and pay particular attention in this area. A famous node called Virchow's node may be palpated right here under the head of the left sternocleidomastoid and indicate carcinoma or problems coming up from the abdomen. Then we come down the posterior aspect of the sternocleidomastoid and the posterior triangle along the anterior border of the trapezius bilaterally. And lastly, the supraclavicular fossa on both sides, extending out laterally from the heads of the sternocleidomastoid. Good. All right. Exposing the scalp. Put your chin down to your chest, chin all the way up. Good. Chin towards me, chin to the other direction, ear to the shoulder, ear to the shoulder. Excellent. Now I'm going to expose the back. Okay, examination, and we see some A lot of moles, a keloid here. Spine is nice and straight. I'm going to percuss with my fist down the spine. Any tenderness there? Looking for CVA tenderness. Any there?
Nope.
Good. Now we'll percuss. And auscultate the back. So I want you to breathe medium breaths in and out through your mouth. And out, big breath. And again. Arm to the side, big breath. Good. Arm out again, up in the axilla, big breath. Good. From there, you can palpate the dorsal spines, which should be in a nice straight line all the way down the back. See the nice mild thoracic kyphosis moving into the lumbar lordosis. The costophrenic angle is marked by the junction of the 12th rib with the spine and now with the lumbar and paraspinous muscles. The lumbosacral junction is easy to palpate at about this level. Notice that it's well below the apex of the pelvic brim, which descends posteriorly. Okay, so this forms the superficial anatomy of the back. Lastly is the latissimus dorsi muscle, prominent muscle we see on the lateral side. This muscle forms this large lateral border of the chest. Again, remember that this overlay of muscle and bone really camouflages the shape of the bony thorax and rib cage underneath, which narrows tremendously towards the apex. In well-muscled chests like this, you may not get a very robust sound. On the other hand, with a thin emphysematous chest, you'll hear a hyperresonance. Some people feel that you can actually palpate those sound waves. Most of us are not talented enough to do that. It allows me to strike a little bit harder. Lift your arm to the side, big breath. Big breath. Good. And then we're going to percuss and auscultate the front of the chest. Big breath. Out. And another breath. Good. Palpate the carotid. Right here at the level of the thyroid cartilage is the carotid bifurcation. Auscultate the carotid. Hold your breath. Good. And once again. over the pectoralis minor muscle, and then up towards the coracoid process on both sides. Right down the border of the pectoralis, and then along the border of the posterior fold of the axilla, which is the latissimus dorsi. And lastly, with the other hand, it's easy to palpate up in the apex and down the neurovascular bundle as it descends into the arm. And they may be enlarged with problems in the hands and forearms. Okay, so we examine the entire chest, palpating areas of these lesions. Most, if not all of these, are macular. Next, we're going to examine the arm. So we want to fully expose the arm, including the axilla, and then posterior aspect of the arm. And we can notice already in this young man the demarcation of the highly sun-exposed areas from the less sun-exposed areas. And on the other arm, much the same thing, as noted from behind, little sunburn last weekend. All right. And then palms. Okay, let's bend the leg up. Sole of the foot again. And then interdigital spaces and nails. Aside from the moles, this all looks very normal. So we do that, and be sure to examine both hands, thumb and fingers. Okay. Let's see, how do we want to do this? Tell me if I'm breaking your finger off. And then we're going to examine the inguinal areas individually. To examine the inguinal ligaments, we're going to do that one side at a time, and you want to expose the area from the anterior superior iliac spine over to the symphysis pubis. The inguinal ligament runs in this direction, and the lymph node beds are inferior and oftentimes a little medial to that. So again, start well above that area, palpating with the flat of your hand and rolling the tissue along. You know you're in the right area when you can palpate the femoral artery, which I am right there. And remember, the lymph nodes run along the neurovascular bundle, so you're basically following that area down into the leg. You want to extend at least 8 to 10 centimeters anteriorly, and don't forget to palpate medially as well, right over to the symphysis pubis. Okay, and then we just repeat that on the other side. Again, exposing the area, anterior iliac spine, down to symphysis pubis, inguinal ligament runs here. Femoral artery is right here, and we will just palpate under and inferior to the inguinal ligament, rolling the tissue, and again continuing down the anterior aspect of the thigh, 8 to 10 centimeters, and extending medially, and right over here to the symphysis pubis. And that completes the examination of the inguinal lymph nodes. Hold your breath, and hold your breath. Good. All right. Excellent. Okay. And you usually need to go up to about a plus 20. Percuss the upper border of the liver. Percussing Traub space, that's the normal gastric air bubble. If there's splenomegaly, it might move in that direction. Take a deep breath, blow it out. Big breath. Checking for splenomegaly, and there's none there. Just relax, and we'll palpate the inguinal lymph nodes. Right up to the inguinal ligament on both sides. We're turning to the sitting position. And I'll move back to the front. Good. And we'll look at the legs, musculature. Just relax. Good. Then we'll check reflexes in the lower extremities. So after checking the muscle stretch reflexes, we check the plantar response. Gently stroke the sole of the foot. I use a broken tongue blade just to give, and very gentle, and we can see the toes flare a little bit. And here's a nice normal response. There we go. Feel that buzzing?
Yes.
Feel that buzzing there?
Yes.
Excellent. And then before we stand the patient, I'll just move back up. Relax your arm. Biceps, triceps. Relax your arm. Brachioradialis, and the same on the opposite side. Relax your arm. Brachioradialis, biceps, and triceps. Good. Hold your hands out like this. Hold them steady. And no evident tremor. The last part is to check vestibular function, so I'll ask him to stand on the floor right in front of me. Move out slightly, put your feet together, and shut your eyes. So he's very steady. I will now push him, see if I can knock him off balance. Lastly, retropulsion. Notice that he's standing in front of the table, so should he go backwards, he'll hit the table and not fall over. Okay, have a seat back on the exam table. Good. Well, thank you very much. That completes a screening physical examination from head to toe.